when people are going through IVF, it's such a stressful process emotionally and physically. Anyway, regardless of MS, for people without MS, the process is emotionally, physically really demanding. And to be able to reassure people with MS more than we have been able to do previously is a real step forward.
We can say that research was useful in order to help neurologists to change their practices. And I think that we should focus on that and try to improve data collection and data evidence in order to have evidence-based practices and try to improve the way we treat and we care women with MS.
I think there's a shift there. I don't think we're there yet, but I think this is a really hot topic where we're going to get a lot of data over the next few years. And hopefully women aren't going to be facing the choice of either breastfeed or resume your DMT, because that's a really hard choice for a lot of people. Hi, my name's Ruth Dobson. I'm a professor of clinical neurology based in the Centre for Preventive Neurology at Queen Mary University, London.
Hi, I'm Emmanuelle Leray. I'm professor of epidemiology in France in the National School of Public Health located in Rennes.
And I'm Brett Drummond. You're listening to the ECTRIMS podcast, the official podcast from the European Committee for Treatment and Research in Multiple Sclerosis. Recent global epidemiological data has shown that approximately 70% of people diagnosed with multiple sclerosis are women. While this may tell us something about the mechanisms behind disease susceptibility, it also raises a number of unique challenges throughout the MS journey. In this episode, my two guests, Ruth and Emmanuelle, will guide us through the different stages of this pathway and discuss the latest research findings that relate to female health. Ruth and Emmanuelle, thanks for joining me. So, as I mentioned in the introduction, we know that MS impacts more women than men, and we've known this for quite a long time. Have there been any recent updates around our understanding of why this might be the case?
So it's true that all the series have always shown that the percentage of people with MS are mainly women. And in the last atlas conducted by the Multiple Sclerosis International Federation, so they identified 2.8 million cases, of whom 70% of women. And it's not so sure if the sex ratio increased over time. It seems that in some places, and maybe in northern latitude zone, there were an increase in the female to male sex ratio, but it's not always found in all series. So it's not so sure if it's really an increase in the incidence of women, or it's mostly, or if it mostly reflects a better case ascertainment.
Yeah, I find the changing sex ratio really interesting, because trying to think about what this tells us in terms of MS underpinning biology. We have a real change in how people are accessing healthcare sort of during the 20th and 21st century. We have way more MRI availability, certainly in Western Europe and America now, than we did 20 years ago. And of course, this is still changing in many parts of the world. And how people interact with their doctors and how medicine operates is a very dynamic field. So trying to interpret the changes in sex ratios on this background can be really complex. We also know that our diagnostic criteria for MS have changed over the past 20 years, and we're able to diagnose people earlier in the disease. And is this driving some of these changes? One of the things that really strikes me is actually how little data there is around underpinning biology of the difference in MS frequency or MS prevalence between males and females. And whilst there is a difference, and we see this across many autoimmune diseases, we don't really know why. And I think there's a real importance in trying to understand why it is that MS and other diseases are more common in females, and some other diseases more common in males. Because if we can really try and understand that, then we may be able to better our understanding of what causes MS in the first place and why some people are more at risk than others.
So during MS Milan 2023, there was a number of really interesting presentations related to female health. And I was hoping that during this episode, we might be able to go through those sort of sequentially in terms of the life of a woman diagnosed with MS. And you mentioned, Ruth, during that, diagnosis is something that's changed over time and our ability to do that. Is there anything specific that studies have shown about this time during a journey for a person living with MS that's particularly important in women?
So if I go first on this one, I think one of the things as a clinician that really strikes me about these studies and how studies are done is by using gender as the only determinant of people's experience, you actually miss out on an awful lot. And what's become really clear in the data that's been published over the past few years, and also data presented at ECTRIMS, is that we need to think about our patients as individuals. We talk about personalized medicine, yet we say, well, let's look at the difference between men and women. That's, those are two very large groups. And actually, when thinking about how people are diagnosed and their experience and process of diagnosis, it's very different person to person. This is influenced for sure by whether they're male and female, but it's also influenced by their experience of the healthcare system, by racism within the healthcare system, by their healthcare literacy, by socioeconomic status. The list goes on and on and on. So I think that whilst we see differences on average in how MS may present and how people may experience their MS between people of different genders, simply of thinking of this on its own doesn't always give us all the answers. And it's really about thinking about that person sitting in front of you in clinic. What has their experience been? How have they experienced their MS? How can we move through this process in that doctor and patient sort of relationship, starting from that point?
Yeah, I fully agree with you, Ruth. And as I said before, I'm epidemiologist, so I'm used to work on groups and comparison of different kinds of population. And really, we don't have now the answer regarding the differences between men and women. And as you said, there are other things, other characteristics, and especially all the things linked to socioeconomic status that are really needed to be taken into account. So I fully agree with you that the neurologist has to consider individually the patient, whether he is a man or a woman.
I do think, though, that sometimes, and again, this is more of a reflection on clinical experience, is that sometimes the questions that come up and how people frame their questions around diagnosis and the implication of their diagnosis can be informed by their gender. And we, in clinic, often get different questions from men and women. Women are often very concerned around pregnancy, around family, around those aspects of their future life as they see it. Whereas in general, males may be more concerned about work, around mobility. And there's some really interesting data showing how different aspects of MS affect people of different genders and from different backgrounds differently, because it's what it takes away from you. So I do think we need to be sensitive to that and think, well, this is the data that we have. We can see that on average, these questions do come up a lot more. They are potentially more important, and actively seeking those out. One of the sessions that I went to at ECTRIMS was around female-specific aspects of care. And there were some really interesting points raised, both by people with MS who are taking part in the session, but also the audience, around neurologists using the right language, around sort of bringing up some of these issues proactively, because they can be really hard to talk about, those sort of inner worries that people have. And we can answer some of those, and we can answer some of those backed up by data around, well, MS now is different from what MS was like 20 years ago. We've got a whole load more information, both around pregnancy, around, how we manage MS around pregnancy, but also around DMT use more generally and prognostication. And that's really important, and framing that to the questions that person has, which may be influenced by their gender.
Yeah. And we're going to get into some of those topics as we go through the episode. But I guess it's that there, in terms of at a point of diagnosis, there are certainly some specific messaging that you may have for a female diagnosed with MS compared to a male, but it's not that there is one script that we can pull out, a template that we can use to talk to all of our female patients with MS, and a separate script for how we talk to all of our male patients. It's got to be a lot more complex and a lot more nuanced than that, as you say, shifting much more towards looking at individuals and shifting towards personalized approaches.
I was going to say, I think there are aspects that as neurologists, as healthcare providers, we do need to make sure we cover with people of different genders, and particularly with females, because they become of real importance when thinking about treatment strategies. So I think there are things that we need to make sure we don't neglect or not do just because people aren't bringing them up.
And so, as with a lot of people continuing on from diagnosis, with a lot of people being diagnosed with MS, particularly females, at a relatively young age, often between 21 and 40. A lot of studies have shown the majority of people get diagnosed during that time. An important aspect during that time for a lot of people at that stage of their life is family planning. And there were some conversations at MS Milan around the conversations that need to happen during the time of preconception. I wonder if either of you would like to share anything around that topic and what research has shown as critical during that period.
Yeah, I think things have really evolved a lot in the past 20 years. I think one important time was the publication of the PRIMS study in 1998 by Christian Confavreux, and it was the first time that we had the evidence that pregnancy is compatible with MS and is not contraindicated in women with MS. And I think things changed at that time, but things also change in the recent years, and especially I think that now all the neurologists are convinced that family planning is really important, and pregnancy have to be planned as much as possible. And I think that when MS is diagnosed among a woman who is of childbearing age, it's really important to consider her wishes regarding pregnancy, not only now but in the future years. And it's really important to anticipate the choice of the disease-modifying therapy based on that. And I think this was not the case before, but now the behavior of neurologists have changed. I don't know, Ruth, if you agree on that.
Yeah, I think that we've seen a real shift over the past 5 to 10 years around how comfortable many neurologists are around using at least some disease-modifying therapies closer to pregnancy. And over the last couple of years at ECTRIMS, including this year, we've seen more and more data come out that helps to inform those clinical decisions around how to use the DMTs, how long to continue them, how much washout period might be needed for some DMTs, which DMTs might be safe to use up to and into pregnancy. And also over the past year, there's been really important data coming out around the potential harms of stopping DMT as well. Because I think as neurologists, we don't want to cause any harm to the unborn baby, and that is very much sort of front and center of people's minds. But we also have to think about the mum, and we have to think about not inadvertently causing harm to mum by withdrawing DMT totally in somebody that really needs disease-modifying therapy, or in an immune sequestering therapy where you may get sort of rebound or relapse reactivation. So I think balancing those risks and benefits, we've become a lot more adept and nuanced around this. And I think this goes across neurologists in general. But it's hard and people find it hard. And one of the really nice things actually about MS Milan was the amount of conversations that were happening around this, and the presentations that were happening around this, around the importance of that really good counselling that takes all the factors into account, not just thinking about stopping everything, but thinking about actually how to manage MS, how to prevent relapses. Because right from the beginning, during PRIMS, people weren't relapse free completely during pregnancy. And so we do need to balance that. I think that one area where there's been some really new, exciting data published is the field of IVF and assisted conception, because that's one area that really has lagged behind the rest of management of pregnancy. And Emmanuelle, I know you've had some really nice data out around this.
Yeah, you're right. There are several experiences that were published recently in France, but also in US and in Germany. So maybe we should start saying that fertility does not seem to be directly impaired by multiple sclerosis, but as in the general population, some women may face difficulties in conceiving. And in the years 2005 or 2008, there were some papers that were published and that showed that there was an increased risk of relapse following IVF, especially when an agonist stimulation protocol was used. And I think that it raised some questions and some fear maybe for women and neurologists. And I think it's really important to say that now the recent studies show totally different results. And there were several papers that were published and that did not find any increase in the relapse rate following IVF. And probably the discrepancy between those studies are related to several things. Probably first, I think that the number of women that were included in this study increased, so we had a higher statistical power. And what is really important, I think, is that probably the previous studies were biased with recruitment of more severe cases. And now we have population-based studies, so with different kinds of women. And I think the third reason for that change in result is linked to use of therapeutic. And now what we can see in the series is that the percentage of women who remain treated until IVF or even at the beginning of pregnancy increased. And really, in my opinion, I'm sure that the changes in the therapeutic practices have improved health of women and decreased the risk of relapse after IVF. So really, my conclusion on that would be that if a woman with MS faces difficulties in conceiving, she should be advised to consult infertility specialist, and the protocol should be chosen based on the fertility problem and not related to MS.
Yeah, and I think this is so important, because I think when people are going through IVF, it's such a stressful process emotionally and physically. Anyway, regardless of MS, for people without MS, the process is emotionally, physically really demanding. And to be able to reassure people with MS more than we have been able to do previously is a real step forward. And I think the other really important thing to emphasize about that, and from the data, is that it's shown that if we continue disease modifying therapy during these IVF procedures, then actually that risk of relapse really doesn't go up at all. And it's a real nod saying, again, we need to think about those risks and benefits really carefully, and think about what is the best way to do this for this family, for the mum and for the baby, and to be able to counsel this, because more and more people are going through fertility treatment. The rates of fertility treatment are going up for various reasons unrelated to MS. And more people are coming to clinic and talking about this. Maybe it's just my clinics, but it's sort of it's very much more coming up, and we've tried to look at this a bit in the UK, and more people are reporting. And a lot of neurologists feel very, very uneasy about this. Just it's outside your comfort zone. It's something that you may be asked infrequently. It doesn't feel comfortable.
I think it's also a really good sign of research answering questions that are really relevant to people living with MS, answering real life questions that are really important to people living with MS, and providing data that can benefit neurologists and healthcare professionals to ensure that they can have these conversations with people living with MS, having the data to back them up and the evidence to back them up to really inform the decision-making process that people might be going through when, they're in these situations.
Yeah, and I think, thinking about that and sort of taking that forward, the other big question that comes up is around breastfeeding and having that data around that. And again, we've seen data presented at MS Milan around the use of disease-modifying therapies in breastfeeding and how we might start to address those questions, because often those questions are not so well addressed. And I'm sure Emmanuelle will back me up when I say that epidemiologically they're incredibly difficult to address, because capturing the exposure of breastfeeding in population registries, which have taught us so much, is almost impossible. And then capturing the long-term outcomes associated with that, again, is very, very tricky. So we're having to use sort of smaller studies. We're having to use very biology-based studies to really try to answer these questions, looking at how much drug gets into breast milk, looking at how much is transferred to the infants. And when you're talking about, very early stages of life in small babies, these studies are difficult to do because actually people are focusing on their babies, and taking part in studies is hard as well. But I think there is data coming out both through, some of which was presented at MS Milan around how we think about this slightly differently and how we think about classes of drugs, maybe rather than each drug individually. And thinking about actually monoclonal antibodies in general and their transfer into breast milk, rather than, again, going drug by drug. And we've recently seen this with licensing procedures where regulators are starting to think about class effects as well, rather than thinking about individual molecules. So I think there's a shift there. I don't think we're there yet, but I think this is a really hot topic where we're going to get a lot of data over the next few years. And hopefully women aren't going to be facing the choice of either breastfeed or resume your DMT, because that's a really hard choice for a lot of people.
Yeah. Well, continuing on from that, around the sorts of conversations that are happening now in that postpartum period around, getting back onto a DMT, what is the latest sort of evidence around that, and what guidelines are we talking about?
So here again, I think that things have changed for the 20 past years, because at the time of the PRIM study, for instance, we identified that about 1/3 of women with MS will experience a relapse in the postpartum period. And now the percentage and the risk has decreased, because we said that approximately 10 to 15% of women will experience a relapse. But still, it remains a severe event, and especially because the women just delivered, and as Ruth said before, she wants to take care about her baby and don't think about her disease and her MS. So I think that we really need to try to decrease again the risk of relapse in the postpartum period. And there were several therapeutic strategies that have been evaluated, but in fact, either high-dose corticosteroids or intravenous immunoglobulin or hormonal treatment, but in fact, there were no evidence of efficacy. So probably this is not the good way. And breastfeeding, for sure, can be a good thing, but here again, it will depend on the women, and some women don't want to breastfeed, so we have to respect this. And probably one attempt that can be very promising is that early resuming of high efficacy therapy can be done. And we can assume that there are several experiences that were published showing that if women with active MS resume early treatment after delivery, it can reduce again the risk of relapse. But as Ruth said before, it has to be discussed based on her choice regarding breastfeeding. And here, I think that we still need to have evidence and to be able to advise neurologists on the best strategy. And I think it's not known yet.
Yeah, and I think following on from that, the other thing where I think there is real opportunity for research and where the questions still aren't answered is around therapeutic lag and the importance of therapeutic lag when selecting DMTs to potentially use in that postpartum period. We know from non-pregnancy related studies that when people start DMT, it doesn't reach maximum efficacy immediately, and that this can be quite different between the different disease-modifying therapies. And taking this into account and trying to really understand, well, when is the risk of relapse in that postpartum period highest for this person? How do we mitigate the risk at that particular point? And how do we select a DMT that enables somebody to, if you like, fulfill their breastfeeding wishes, so works with that, whatever that is, but also minimizes that risk of relapse, and trying to tease out the different factors that might be important in that, which, as I said, includes therapeutic lag, includes mode of administration, includes excretion via breast milk, acceptability, and the changing hormonal profile of women during this period, and also changes in body composition. I think this is a slight aside, but we understand very, very little about the impact of body composition on DMT metabolism and DMT efficacy. And actually, I think this is really, really important. We give everybody the same dose pretty much of all the disease-modifying therapies, regardless of whether they're male, female, 60 kilos or 160 kilos, pregnant or not pregnant. Those kind of things also, we do need to be thinking about those, and we do need to be thinking about those in a research setting, because I think they will be important clinically.
I think what's really interesting, having listened to both of you speak, is how much progress has been made recently, answering some really important questions and seeing what research is able to provide. We've already touched on a little bit with some of the things you were just saying there, but looking ahead as well, what for the two of you, what do you think should be the biggest focus areas in terms of female health in MS? And is there any data or questions that you're particularly looking forward to seeing answers to over the next little period of time? Difficult question.
Difficult question. I think we need better data. I think we need better data that captures the individual characteristics of people, but at a population level. We need more granular population data, particularly around female or gender specific health. For example, I mentioned that around breastfeeding, it's just not captured in population level databases in a meaningful way. So I think without the data, it's very, very difficult. So I think that's the first thing. I think that over the next few years, where we need to go is we need to go around really focusing on treatment strategies. We've got loads of treatments for MS now, but more refined treatment strategies that enable us to address those real areas of need. And the other thing is treatment strategies and more information for people with progressive MS or more disability in MS, because there's a real dearth of information around people with sort of mobility, difficulty with mobility, the higher range of EDSS, more disability, and how they experience pregnancy, how to manage things during pregnancy, how to really offer the optimal pregnancy postpartum experience for these people. Because at the moment we assume it's sort of the same because we don't have the data to inform their care, and I think these people can feel very, very isolated. That's a few things, so I'm going to stop now.
Yeah, I agree with you. I think that for relapsing remitting MS, we have recent treatment, and for sure we need to look at them and to increase our experience on their use before, during, or after pregnancy. Of course, you mentioned women with progressive MS, and really there is lack of knowledge and lack of evidence in this group of women, or globally on progressive MS, and especially because there are no treatments. And for sure, we need to increase data collection on that. Maybe the last thing I will add is related to the risk of social inequalities. We started the podcast with that, and I think it's really important to consider socioeconomic characteristics of patients with MS, whether they're men or women. And I think that health literacy and access to access to healthcare services and all of this is really important. And in my opinion, we have few evidence now on risk of social inequalities in MS, but there are so many fields and other health and chronic disease that found many social inequalities that quite convinced that if we look for that in MS, we will probably find some result. So really, I think that we should also focus on getting detailed data on social and gender-specific inequalities. And especially because you mentioned before, Brett, that there were changes in the past, and we can say that research was useful in order to help neurologists to change their practices. And I think that we should focus on that and try to improve data collection and data evidence in order to have evidence-based practices and try to improve the way we treat and we care women with MS.
Thank you, Ruth and Emmanuelle, for this fascinating discussion that we've had during this episode. And thank you for all of the work that you've both done in this area as well to help guide some of these conversations. And thanks everyone for listening. Once again, I'm Brett Drummond, host of this podcast episode. I'm also co-founder of MS Translate, an independent resource centre that aims to simplify the complex wealth of information about MS for the greater MS community. The ECTRIMS podcast is produced and hosted in collaboration with two key partners, MS Translate and the MS Journal, a peer-reviewed international journal that focuses on MS, neuromyelitis optica, and other related autoimmune diseases of the central nervous system. The ECTRIMS podcast is supported by an educational grant from Novartis, Roche, and Alexion AstraZeneca Rare Disease. Educational grant providers have no input on the podcast series content. You can read more about the topic of this latest podcast episode and more on the ECTRIMS website, ectrims.eu. Do subscribe to the ECTRIMS podcast on your favourite podcast channels and follow ECTRIMS on X, formerly Twitter, LinkedIn, Facebook, and YouTube.